at the end to speak directly. So thank you again. My name is Justine. I'm the manager of clinical trial recruitment at Toronto Memory Program, and I'll pass it over to Dr. Cohen.
Thanks so much, Justine. Excuse me. Yes, my name is Dr. Ian Cohen. I'm a physician here at Toronto Memory Program. And my background is actually in family medicine, but I've been practicing in this area of aging and memory now for the last 15 years. And I work alongside my wife, Dr. Sharon Cohen, who some of you may have heard of. She's the more well-known of the two of us in terms of her contribution to Alzheimer's disease research and moving clinical trials and new treatments forward. But I've been well trained both here and at home. So, and I've been involved in this for a long time. And Justine and I thought that in terms of the individuals who see our patients, who are a major part of our team in terms of managing the medications that we currently use and providing education to patients, we thought that local pharmacies play a very important role in this treatment, and that they may not be aware of everything that's going on. Obviously, you see treatments when they've been approved by Health Canada, but there's a huge number of studies and new treatments that are being observed and analyzed in clinical trials, and you may not be aware of what we do, but I think there's a role that you might be able to play to help patients in this situation. So Justine has already gone through some of these. And this is the outline. We're going to talk about general Alzheimer's disease information to start with. How do we know it's Alzheimer's disease? What are the current treatments that you would obviously be familiar with? What's coming very soon and what's further off in the distance? Why does it take so long for us to find new treatments? And what can you do to help? And what can we do to help you help us? And that's what we're going to try and cover here. So what is Alzheimer's disease exactly? We just assume people know, but it's not a given. It's a chronic neurodegenerative disease that destroys brain cells over time, causing impairment in memory and thinking ability. So other areas of cognition, such as language, spatial orientation, attention, calculation, all areas that our cognitive brain does are affected in time. Short-term memory is usually the initial presentation. Alzheimer's disease is not a normal part of aging. It's a clear abnormality. Alzheimer's disease happens to be the most common cause of dementia. So one of the questions we'll talk about is it dementia? Is it Alzheimer's disease? That's a common concern people have, and we'll explain how those two mesh together. What we do know is that Alzheimer's disease is, it's a tsunami. It's staggering in the number of people that are being affected by it because of the baby boomer generation reaching and into the age where this disease is becoming common. It creates severe morbidity in individuals who have it, meaning that over time you're basically rendered incapable of doing the most basic of your activities of daily living. It is a fatal disease. As your brain fades, it controls everything that your body does, and unless some other disease comes along to end a person's life, then Alzheimer's disease will end that life. But we often at the end say, oh, they died of a heart attack or they had pneumonia, but it's really the Alzheimer's disease, the failure of all their systems to work. There are enormous costs of care. We think about people that are in long-term care, but there's a staggering cost to the people that are looking after individuals at home before they ever get to a long-term care facility. People are having to take time off of work or leave their work or become what's known as the sandwich generation. They've still got kids that needs looking after, and now they've got parents that are failing, and the costs to society are staggering. It's more expensive, in fact, than heart disease and cancer in terms of the impact. And in about 2016 in the UK, Alzheimer's disease overtook heart disease as the leading cause of death in England. there's a challenge because often it's underdiagnosed or it's misdiagnosed or there's a late diagnosis. And in fact, it's only diagnosed in about 50% of patients and only after several years of symptoms. So you might get a patient who comes to a doctor a few times over the course of an extended period of time, and the doctor may not know the appropriate tests to run or may not take the symptoms seriously until it's clear, oh, well, now we have a significant problem. And by then, often the choices for treatment are too late, or more limited in their value or their benefit for the patients. And in some cultures, it's not diagnosed. It's well, so-and-so is just getting old, and what do you expect? Well, normal aging isn't Alzheimer's disease, but in some cultures, it's not discussed. There's a stigma associated with it for the family and for the patient. So, and as we talk a little bit later, you're going to see why it's more and more important that we identify the disease early. What are some of the early symptoms? Well, the most common thing is forgetting recent events or recent conversations. So it's the short-term memory. It's the ability to take a piece of information that you've just learned, juggle it around in your working memory, and then lock it away sometime in some place that's going to keep it as a long-term memory so you can access it over and over. And we see that often manifested by people asking repeated questions of the same thing that you've already answered. That's a common symptom, and someone will go, well, I've already told you that, and the person goes, no, you didn't, or they just don't remember. Finding the right word is one of the common presentations, or the names of people that you've known for a long time, or names of actors or movie stars, or street names. Those are common language presentations. Most people present with a short-term memory problem. That's the majority. There is a language presentation, however, to Alzheimer's disease where memory may be preserved, but communication is severely disrupted. Over time, we hear about people, they can't find their way around. And now we're fortunate we have GPS. People are able to stay active in their driving for a longer period of time because they're not getting lost the way they used to, but they are perhaps moving further and further into the disease before we identify that there is a problem. They can't quite make that map in their brain. They'll start to notice problems with decision making or planning or completing multi-step tasks where they need focus and they need to be able to attend to what they're doing. They get distracted and then they forget. And the common example would be they remember that they want to do something. They have to go to another room to do it. Somebody asked them a question in the intervening moment. They go to the room, can't remember what they're going to do. Now, that's a common complaint people have when you're distracted, as we all are with our phones and everything else that's going on. But with time, that becomes evident that there's something more than just common distraction going on. And really, what is critical is that some people will just come and say, you know what, I'm not who I used to be. I don't remember things as well. And in our office, we'll do cognitive testing with them, or in a doctor's office, and they say, well, you know, your testing looks fine, everything looks okay, but they know there's a change. And often what you're seeing is between the point where they used to be to the point where they now are, there's a significant drop, but here might be the level that the test starts to show the abnormality. So they've identified this difference, this drop, before a test will show it. And that's actually predictive of progression in Alzheimer's disease. There's a constellation of behavioral symptoms that go along with this. There's irritability and anxiety. Sometimes even depression is the presenting problem for Alzheimer's disease. And some patients have the unfortunate situation where, because of their short-term memory, they don't remember that they have a problem and their insight is impaired. So it'll be clear to everybody that they have difficulty. They can't do X, they can't do Y, but for them, no, everything's fine. There's not a problem, because they don't see the disability that they're experiencing, this loss of insight, which can be very challenging. Someone's trying to help them do something and they don't believe they need help. Now, this is sort of the trajectory. This is the difference between what normal aging looks like and what Alzheimer's disease looks like. So across the left-hand axis is cognitive decline, and across the bottom axis is time in years. And in fact, that bottom line is a 30-year stretch. That's how long we now understand Alzheimer's disease is. So across the top, everybody experiences slight cognitive decline while they're aging. And you can see these two sort of lime green lines that show variable decline. Some people decline a little bit more, and then they sort of plateau out this blue line. But the first stage of Alzheimer's disease is actually silent. The brain is changing, though. The brain is accumulating pathology. The next slide will tell us about that pathology, but it's already building up because it takes a long time to build up to the point where it's affected enough brain cells that it now causes symptoms. But even in this preclinical or the late stages of preclinical, people may notice the change. It's not detectable on test. It's the stage where the patient knows, but the doctor doesn't. That's one of the things they describe. And we would call that stage subjective cognitive decline, meaning the person's aware there's subjective complaints, but objectively there's no impairment. And that's typically the last part of that preclinical. And the preclinical's maybe 15 to 20 years before symptoms. The first symptomatic stage where there's actually some impairment is MCI, or mild cognitive impairment, where now the cognitive changes are a little bit more evident. The patient may notice, well, usually the patient notices, the family starts to notice, and it's usually at least in one cognitive domain. We talked about short-term memory being the main one, and there is now objective evidence of impairment. So when we do a cognitive test, like a Montreal cognitive assessment, which is a good test for early symptoms, we see difficulty remembering a list of words. So objective evidence, but they're still able to do their high-level daily activities. They can look after their medications, they can reorder from the pharmacy, they can prepare meals, but maybe they have a little more difficulty following a recipe. They can go shopping, but maybe they need a longer list, or they need to think about things a little bit more. So you see they're making strategies or adaptations in that mild cognitive impairment stage. And this stage lasts, let's say, an average of 5 years. It's very slowly progressing. You can see the slope of the curves, not as much as the next stage, where the last stage of the disease, actually the final stage, is dementia. And dementia describes the situation that they find themselves in. And basically, they have a cognitive impairment that's now severe enough to interfere with everyday activities. So they can't order their medicine, or they can't look after their medicine, or you start to notice they're blister packing their medicine because they can't remember to take it, or they can't shop, or their finances now have to be taken over by a family member, or now they're at the point where they can't drive anymore. It's not safe because they can't process the information fast enough. And what you see here is sort of an outline of about 4 stages. There's mild, moderate, moderately severe, and severe. And usually we use a cognitive test called the Mini Mental State Exam, or the MMSE, to help us distinguish between those stages. It's a test out of 30. If you have, say, 20 to 26 out of 30, you'd be in the mild stage. Between 19 and 10, you'd be in the moderate. And in the severe, it'd be less than 9. And in the severe, you really can't manage your basic activities of daily living. You can't do your toileting, you can't do your personal hygiene, you have trouble eating, all of those things. As far as the people that you see where you're giving out, let's say, donepezil or galantamine or the cholinesterase inhibitors, they're going to be ones that are typically in the mild to moderate dementia stage, in part because that medicine isn't indicated for people with mild cognitive impairment. You may start to see mild cognitive impairment when people are confusing their prescriptions and forgetting to reorder them and forgetting to take them, or it's taking them longer to renew their medicines because they're forgetting them, but they may not need or be prescribed until the mild to moderate stage. And usually memantine is more in the moderately severe or severe age. And what you can see is in this graph, the cognitive decline is terminal, right? It's at a certain point, you have no more cognitive function. This is the pathology of Alzheimer's disease. There, in the brain, there's the formation of amyloid protein plaques, which you see on a slide here of someone's brain tissue had passed away. And the second pathology that develops are these neurofibrillary tau protein tangles. And these are actually cells that have died. So plaques sit on the surface of the cells, and this amyloid protein accumulates in this preclinical stage. It takes about 15 years for it to reach a critical level where enough cells have this plaque on them that the plaque triggers pathology to develop inside the cells, and ultimately the cells die, and that's what those tau tangles are. And it seems like the disease progresses as the tangles accumulate. So they're a later finding, but they're more clearly associated with symptomatic progression. So this is an example of that. What you can see here, I don't know if you can see my cursor, maybe not, but the first line that you see here on the bottom, it says cognitively normal. And look how long cognitively normal goes, but look at how much pathology develops. That first red line, that's amyloid accumulation. It's 80% of the accumulation occurs before the first stage of symptoms, mild cognitive impairment. You see the next line, the tau-mediated tangles. And what you can see is here, again, by the time the person develops mild cognitive impairment, they already have a fair amount of damage to the brain. The third line is the brain structure. So where we might see changes in the volume of different parts of the brain, like the hippocampus might look smaller. And the second to last line is actually the memory impairment. So a lot goes on before the person's memory impairment even starts in this mild cognitive impairment stage, and then progresses in the dementia stage. And at the last line is their actual clinical function, where they're independent at the start, but then over time their cognitive impairment increases. So how do we actually know if it's Alzheimer's? People come to us, and historically the way we've done this is it's a clinical presentation. They tell us their story. We identify the pattern of presentation. We try and ask some questions about other types of impairment, other types of dementia, like is this a pattern that fits with frontotemporal dementia or Lewy body dementia like Robin Williams had, where they might have hallucinations and act out their dreams. Well, that's not usually a part of Alzheimer's disease at first. We'll collect all this information. We'll try and think about what are the things in their life that could present with impairment of their cognition. Are they chronically depressed and it was never treated, or things like that? And then once we have this sort of idea that, well, this could be mild cognitive impairment, or maybe this is dementia, we'll do some tests that rule out other causes. What's the common one that we'll use? We'll do blood work to look at their thyroid, because if you're hypothyroid, your brain becomes sluggish, and that could cause symptoms that are similar. So if it's thyroid, we would treat their thyroid and see if their symptoms improve. If they happen to be vitamin B12 deficient, because they're maybe a lacto-ovo vegan and they don't eat meat, and their B12, which is really important for myelination of brain cells, is in their boots, and it's been like that for long enough, that could also present with a cognitive decline. And then we make a diagnosis. But what you see here is I haven't mentioned any tests for Alzheimer's disease, because historically, and not even historically, currently, in most of the physicians who send you a prescription for Alzheimer's disease, they've made this diagnosis clinically and without a confirmatory test. So in 2011, there's been different guidelines over time, but in 2011, the National Institute of Aging came out with a guideline for the diagnosis of Alzheimer's disease, and they defined these stages that we've just talked about, these preclinical Alzheimer's disease, the prodromal, where they have mild cognitive impairment, and they said, look, dementia is the end stage of Alzheimer's. But they also recognized, well, we have some biomarkers available to us now that can actually see Alzheimer's pathology. So an MRI, where they're looking at the volume of different parts of the brain, might give you an idea. If the brain's overall smaller, that doesn't really tell you, because that's what happens with normal aging. But there's a thing called a glucose PET scan, where you can see some of the metabolism changes in the brain. And then there's now an amyloid PET scan. We can take a picture of the brain. We've been able to do this for many years in clinical trials, not in general practice, where we can actually see amyloid buildup in the brain. We can also do a lumbar puncture or a spinal tap, collect a few milliliters, like we only need 2 milliliters, and we can send it off to labs. Unfortunately, no labs in Canada, but we can send them off, as we do, to a lab in Amsterdam. It's a world-renowned lab, and we can measure directly in the spinal fluid the amyloid and tau levels and see if they're abnormal. And what that tells us is it gives us an indication of what's going on in the brain. So if amyloid's sticking around in the brain, we all make it. It should be cleared out. We should see lots of it in our spinal fluid because we're clearing it out. But if the level in our spinal fluid is low, that tells us, you know what? Not all of it's getting cleared out. It's getting stuck there in the form of plaques, and that's causing damage. So we can measure that in the spinal fluid. And likewise, tau's formed inside brain cells. It has a really important role normally. And when Alzheimer's disease comes along, it disrupts its normal process. As the cell dies, the tau protein is released into the spinal fluid, and we can measure an elevation that tells us, you know, brain cell damage or neurodegeneration is actually occurring. And nowadays, we actually have blood tests. We finally have blood tests to detect amyloid and tau in the bloodstream and use those to determine as a biomarker, does the person's cognitive impairment, is it due to Alzheimer's? The kicker here is that all of these pretty much are still only available in clinical trials. So most of the patients you see, their doctors made a diagnosis without the help of a biomarker. PET scans can be done, but they're not cost covered yet by OHIP. Eventually they will once we have a new treatment, but right now they're $3,700 and you don't need it to prescribe donepezil or any of the current medicines that we have. But these have all been available to us in the research world. And one of the benefits of participating in research studies is that people access this so we can determine, look, is this or isn't this Alzheimer's disease? This is what a PET scan looks like. And what you can see here is it's all lit up. All that red is where a tracer has attached to the amyloid plaque that's bound up on the brain. And we can measure that and determine if people have a biomarker that is positive for Alzheimer's disease. And we can say, look, your mild cognitive impairment is on the basis of Alzheimer's, or thankfully, it's not. We now actually have this very unique technology at our office. It's a retinal scan for detecting Alzheimer's disease. So using a special hyperspectral camera, we can detect amyloid in the back of the eye. It's not an invasive test, there's no dye involved. And there's a study taking place at our site where people have these images taken of the back of their eye, and then either they've had a PET scan because they've been in a study, so we can then compare how good is the eye test compared to the PET scan, or as part of this study, they have a lumbar puncture or spinal tap where we can measure the proteins and compare to the eye exam. And people get all, oh my God, it's a lumbar puncture, sticking a needle in the back. That sounds scary. We do 2 or 3 of these a day. It's not a big deal. If we want to check your kidney or your liver, we stick a needle into a vein and we collect some blood. If we want to measure your amyloid and tau proteins, we put a tiny needle between the vertebrae and we collect some fluid, and it's really not a big deal. People tolerate it incredibly well. And in this study, they actually get to access that spinal fluid assessment to determine is this or isn't Alzheimer's disease. So what's interesting is when people present to their doctor and we say, well, yes, this looks, this is mild cognitive impairment, or oh, they have dementia, this is Alzheimer's disease. When they started adding these biomarkers to the studies, what they found is that in people who were told, well, your mild cognitive impairment is on the basis of Alzheimer's disease, only 50% of them actually had Alzheimer's biomarkers. So we were wrong half the time. And in dementia, we were only right 75% of the time, based on the lack of the presence of amyloid, and the 25%, they actually had something else going on. So now we have a test that we can actually rule in Alzheimer's disease. So the value of these is it gives us better diagnostic certainty. We can detect the disease early, meaning we can detect Alzheimer's disease before a person ever has symptoms, and they can participate in an Alzheimer's prevention study where we actually remove the built-up amyloid from their brain, which is remarkable. And this study is going on. It's called the AHEAD study, and individuals participate. They have a PET scan to see whether or not they have Alzheimer's pathology. And if they do, then they go into a treatment study where they might receive the medicine, they might receive the placebo, and we monitor them. And at the end of the study, we're going to learn, does this medicine, by removing this accumulated amyloid, prevent them from progressing along all those lines that you saw in the previous graph? So we can intervene at the preclinical stage, or when people have mild cognitive and mild dementia. And the benefit of this also is if you've developed a medication that is designed to attack some aspect of the Alzheimer's process. If you enroll people in your study who don't have Alzheimer's disease, of course, the end result is your study's not going to answer the question because you've got all these confounding variables of patients who don't really have the disease. So having these biomarkers has allowed us to get much better at determining, is a drug really helpful or not? Some studies will actually use these biomarkers as measures of disease progression. So we know the tau protein's particularly good about this. We just talked about how we can use them in prevention trials, but that they're not yet available in practice. And in fact, when somebody comes to you and there's a prescription, or you see a note that says they have mild dementia due to Alzheimer's disease, really what they're saying is they have mild dementia due to probable Alzheimer's, because unless they've had a biomarker, you can't say it's definitive. You can when they pass away and you do their biopsies, but not until that point. So who gets these biomarker tests? It's everyone basically who's in a clinical trial taking place here. But people don't know about this. And a lot of clinicians don't actually know about it, and pharmacists as well. And I hope some of you are aware of it because you see it in the literature, but this is a new thing. So of the treatments that you're currently providing to your patients, there's two categories. We've had them for 20 years. There's cholinesterase inhibitors that work by boosting the level of acetylcholine in the synapse between brain cells so that it's improving or enhancing or trying to preserve connectivity between a brain cell. So you want to remember a word, you send a signal in one nerve along another nerve, and in that gap you release cholinesterase or acetylcholine, and the signal goes through and you get the word. Well, in Alzheimer's disease, the acetylcholine production drops because cells are dying, and you don't find the word as easily, or you don't lay down the memory. So the medicines that you're using boost the level of that neurotransmitter and can give some modest benefit. And that's generally indicated for people who have mild to moderate dementia. We don't have a medicine for mild cognitive impairment. As original studies for this didn't show that it was helpful at that stage. Glutamate modulators, you'll be familiar with memantine. That's usually used for moderate to severe dementia, because where it seems to help best is when people have moderate to severe impairment in their basic activities of daily living. And that's where it showed effectiveness. It was able to preserve some degree of independence at that stage. Now, people will say, well, I've been taking this medicine and it's slowing the disease down and I'm not progressing. And that's what they've been told by their clinicians. And unfortunately, they've been misinformed. I hate to say that, but this treatment only affects the symptoms. It does not slow the disease, or it does not prevent underlying damage. In fact, what it does, based on this graph here, is again brain function, time across the bottom. Straight line is normal disease progression. The second line above that is when you add a cholinesterase inhibitor, there's an improvement in brain function. So it sort of backs them up 6 months or so. And as long as they're taking the medicine and they've responded, then they continue to get benefit from that medicine. But people will go, well, it's not working anymore, I'm getting worse. Well, they're getting worse because the underlying amyloid and tau pathology is killing off their brain cells, but they're still getting support for their acetylcholine. And so people will say, well, it's not getting worse, I want to stop. And we go, well, you might want to hang on there, because if you stop, what might happen is that line might drop back down to the lower line, and we might have trouble getting you back up. So we don't want to risk losing whatever benefit that you're getting. The dotted line above that would be studies that are looking for medicines that boost that level even higher. So symptomatic treatments that maybe are helpful but more effective than what we currently have. And there are studies taking place with some medicines that are just looking at symptom benefit. What we really want, though, is treatments that do this, that modify the trajectory of the disease. So what you see again is that natural history of the disease progressing, and the dotted line is if we can find something that aborts or blocks or limits the amyloid pathology or the tau pathology or any of the other things that are going on, then the disease progresses more slowly and brain function is preserved. People stay independent longer in the community or maybe at work. They don't require the same support, or it's not as costly. They stay out of nursing homes longer. That's really what we're looking for. And likely what's going to need to be in place is to get this up to that solid line that's going horizontal, the stabilization line, is we're going to need a cocktail of drugs, much like you see in HIV, because they're working on different aspects. And we need probably medicines that work against the amyloid, medicines that work against the tau, maybe medicines that work against inflammation to get the optimal benefit. And certainly the earlier we start these medicines, the better, because we have brain left to preserve. And that's a big problem. Sometimes patients are sent to us after they've exhausted all of the, the cholinesterase inhibitors and their memantine, and now they go, oh, let's find a clinical trial. And we're going, well, I'm sorry, it's a bit late because, too much of the disease has been damaged, and there's not so much we can do. So the earlier we can identify people, or the earlier people participate in studies, the better chance a drug has to work. And there's a lot of treatment approaches. I mean, you're familiar with all sorts of diseases like diabetes that has so many different strategies now to address the different components of the disease. And in Alzheimer's disease, we're 20 years behind cancer in a way, and that it's taken a long time because the brain is so tricky to figure out what are the pathological processes that are going on that we can target to try and intervene. So if you go around the circle here, are they neurotransmitter-based therapies, or is it signaling therapies in terms of how the brain speaks to each other, or anti-inflammation treatments, which have certainly been tried. We've used NSAIDs as treatments for in studies for Alzheimer's disease, and mitochondrial targets. They're the engine for the body, and in fact, in brain cells that are affected by Alzheimer's, they're hypermetabolic. So maybe if we can target mitochondria to either produce better or survive or tamp down that high activity, maybe the cell will last longer. Vaccines would be wonderful. If we could give a vaccine that would prevent amyloid from forming and accumulating, that would be great. We've been involved in some vaccine studies here as well. About oxidative stress reducers, the ones that we talk about are eating blueberries and fresh fruit, and those are antioxidants. Well, in trials, we're looking to identify others that are maybe a little bit more effective. Anti-amyloid-based therapies we're going to talk about in a second, because we've been involved in those for a long time in this field, and tau-based therapies. This is I call it a happy graph for pharmacists, because it means lots of drugs are coming. This is every year this graph comes out, and it shows the Alzheimer's disease development pipeline. Around the outside are all the drugs that are in phase 1. In the mid-range are all the drugs that are in phase 2. And in the center circle are all the drugs in phase 3. So as you know, drugs to get to your shelf have to go through these 3 phases. They do preclinical studies, right, in the petri dish and animals, and then they go to phase 1. And if they show safety or they show good pharmacokinetics or pharmacodynamics, then they will pass on to phase 2, where now we're looking at tolerability and starting to look at some efficacy. And in phase 3 now, once and for all, we're determining, look, does this drug work? Does it help slow the disease or improve symptoms? And this pie chart is broken into the different approaches. There's biological agents. You'd be very familiar with those from all the monoclonal antibodies that you use and dispense to people for Crohn's and colitis, for rheumatoid arthritis, for a myriad of disease that you know better than I, that I've tried to address the different components of those diseases. In our case, the targets are amyloid and tau. And I'll talk to them in a minute. And then there's a whole bunch of these other approaches that I showed in the previous slide, and those can be identified there. And many of these molecules, if I look through this list, many of these molecules were involved here as a trial site. So people are participating at different stages in phase 2 and phase 3. So this is kind of a spectacular shot. So, I showed you that picture before of a PET scan full of amyloid, and what you see here is on the left, PET scan full of amyloid, and on the right, it's the same person's brain, no more amyloid. And that's from aducanumab, which is a monoclonal antibody that we were involved in studies with Biogen that clears amyloid plaque and in fact slows the disease down. And there's been some contention around it because the second study was stopped early, because the assumption was, well, it didn't appear to be working, but in the end, it was actually working. They just didn't have enough people on the higher dose for long enough. But it led to sort of a partial approval by the FDA in the States, and Biogen decided not to submit to Health Canada for approval here. But this is what we can now do. We can completely clear the brain of amyloid. There's another medicine here called donanemab. It's the third one down there. And within 6 months, the people go from a positive PET scan to a negative PET scan. And now the phase 3 study from that has shown that's effective in actually slowing the disease down. The second drug that you see, lecanemab, is, you may have heard in the news last week or the week before that the FDA advisory board, or AdCom it's called, had advised the FDA that they support approval of lecanemab. And what you're going to hear on July 6th is the FDA decision, most likely to approve this drug, so full approval. So it's been available in the States as an accelerated approval for the last year or so, but it hasn't been cost coverage, so not a lot of people have been able to use it. But now with this full approval, the Medicare and Medicaid in the States will most likely jump on board, and it slows the disease. How much does it slow the disease? Well, a significant amount. So on the main endpoint for this study, the clinician's dementia rating scale, it slowed the disease by 27%. In terms of slowing the decline in the instrumental activities of daily living, it was a 37% slowing. And in patient-related quality of life measures, there was a 56% less impact on quality of life on people on treatment versus people on placebo. And the chance of progression to the next stage of the disease was reduced. So this study that was reported here was for people with mild cognitive impairment or mild dementia, and they didn't progress as quickly to the next stage of their disease. So the MCI took longer to get to mild dementia, likewise mild to moderate, and July 6th is the date. So this medicine has been submitted to Health Canada. Health Canada has accepted the submission. They are starting the review process, but the expectation is that it will take 1 year for that review to take place. So we anticipate in 2024 we'll have an answer, and you may well be providing prescriptions for lecanemab for patients here in Canada, which would be fantastic. The first disease-modifying treatment in Canada ever for this disease. And we've actually been a site for all of these clinical trials, all of them. So some of your patients may well have been in these trials getting this treatment. And for years, people have been on lecanemab here for 5 years now as part of the ASI Clarity study, and they've been getting this drug ahead of everyone else. So that is one of the benefits of participating in a clinical trial, that you get access. Now, of course, there's entirely the possibility, and historically this would be the norm, that the drug doesn't work. It's one of the risks of participating in a clinical trial, that in the end we find out, you know what, the drug doesn't work. But in the meantime, until we have these disease-modifying drugs or something to treat this disease, we have nothing to slow this down. So at least participating in a study gives people the opportunity to either benefit themselves or benefit society. I can tell you that the people that have been in these studies that have shown benefit, knowing that these drugs are now coming to market, it's a huge boost for them to know that they have contributed to finding a treatment that's going to help millions of people. And you're well aware of this. I mean, your shelves are filled with drugs that have gone through clinical trials because people have participated. And there's a challenge. A lot of people don't know trials exist. They don't know that all of these approaches are taking place here. So this is a list of our studies. Cassava is a sponsor of a medicine called sinufilam, which is in phase 3 and restores the shape of tau protein. Semaglutide, you're very well aware of from diabetes. There's lots and lots of reasons why this drug will likely slow Alzheimer's disease. And so the Evoke and Evoke Plus, and there's another study with Ozempic now that's just starting, are looking at slowing mild to moderate Alzheimer's disease. We are the first site in the world to give an Alnylam intrathecal gene silencing treatment for Alzheimer's disease. So amyloid precursor protein is a long protein that's cleaved by two enzymes into the dangerous part of the amyloid that causes all this. And now people are receiving a treatment that actually stops that formation of the amyloid precursor protein. And we've been seeing their spinal fluid results, which we see no amyloid forming, no pathology forming. So it's pretty spectacular. It's in phase 1, but people are still joining that. And we have this AHEAD study, which is lecanemab as Alzheimer's prevention, which we think will likely be much more effective if we can start it before symptoms. There's a new study that we've started by Biogen. It's called the Celia study. It's another treatment that's given intrathecally, and it's a modified anti-senescence oligonucleotide, which actually stops mRNA transcription from forming tau. So we shut off the tau pathology from forming. And so that study's just started. And there's another aducanumab study that's taking place, and coming in the future will be another Eli Lilly study, the Trail Runner study, and with a different approach. And the reason we have all these studies in part is because these are all good approaches, and also for people who might be on one medicine or another medicine that might be conflicted, or they couldn't participate in one study or another. The more study we have, the more opportunities for people to find a study that they're actually eligible for. So why does it take so long to get new Alzheimer's disease treatments? Because the disease mechanism is complicated. So finding people to, mechanisms to attack has taken a lot of time and needed a lot of resources to get to this point. The average study takes 18 months to finish for each participant. Why does it take so long? Because it's a slow moving disease. So if we want to see at the end of a certain period of time, did a drug work? We need to follow people long enough that there's separation between the placebo group and the treatment group. So if you only follow people for 6 months, the disease doesn't really progress. You're not going to see enough in that time frame. You need the 18 months for the bare minimum to see this difference. And not everybody starts together. So if there's an N of 1,000 for a trial, and there's 100 sites around the world, let's say each site's going to contribute 10 people, because it's not that easy to find, someone who fits the study. If it takes 18 months to enroll everybody, then it's another 18 months to the trial finishes. So it's 3 years to finish, right, till we get our results, or till we can even start analyzing the results. But if it only takes 6 months to enroll, then it's only going to take 2 years to complete. Right? So part of what we're asking here is you're in a position to understand these sorts of important concepts. You see these people on a regular basis. And in fact, you may see them, but I would guess that your staff probably sees them a lot more in some ways than you do, because they're the ones who are actually handing out the drug to them when they come to pick it up, or giving it to the family member to pick up. And so we're hoping that you'll share this presentation with your staff, because they like to, feel that they are contributing, that they have a role to play, and can make people aware of these studies. So what about the studies we're doing? Is it just like some big black box and, it's a study and, oh my God, what's happening? Well, so all the studies that we participate in have first been approved by the FDA, then Health Canada, and are ethics approved. So we can't do anything until a study's gone through all of these steps. There's significant regulatory oversight over the entire course of the study. So we have monitors that come every 6 weeks to check that we're doing the right things according to the protocol and following the rules of research. Studies are voluntary. That means people are educated by people like Justine about the study. They can ask all the questions they want. They can then decide if they want to participate. And likewise, in the middle of a study, if they decide, you know what, not for me, then they stop. Or if likewise we saw an issue, a side effect or a safety concern that we thought was a problem, we'd say, it's time to stop for you. There's never a cost to participate in a study. In fact, the study will say to each participant, it might be $50 per visit for travel expenses. It's not meant to get rich on. It's meant to make sure that the person doesn't incur any costs. And important to recognize that they would stay on their current treatment. So their cholinesterase inhibitor or their memantine, they would not stop those to go into a study. They're sort of baked in. Theirs are helpful for them. And so they continue. They get to participate with a study partner of their choice, because we want to know from that study partner, well, what do you see? How are they doing? What's changed? So every 6 months or whatever, we're going to ask them a whole bunch of questions. And in the end, that's one of the ways we're going to determine if the drug works. And they get a lot more access to experts in the field. So if you're coming for a research visit maybe once a month or once every 3 months, you're going to see myself, or you're going to see Dr. Sharon Cohen, or you're going to see another neurologist or a specialist who's much more on top of the problem. So families get a lot more attention in terms of what sort of supports they need, and we can intervene a lot sooner than maybe the family doctor has time for. And not only that, but we're on call 24 hours a day, 7 days a week throughout the study for them. If there's ever a problem, then we need to know about it so we can act on that. So how can pharmacists and their staff help? Patients won't know to ask for trials. So we're asking you to improve the awareness of clinical trial opportunities for your patients, and that they can access these new biomarkers, and to encourage patients to participate to help find new treatments and possibly benefit themselves and others in the future. And the way that we'll keep you aware of what's going on, so it's sort of top of mind, is we'll send you updates whenever there's a new trial. We'll send you sort of whatever we can about the study medicine, because probably that's of interest to you, how the mechanism of action and some of the details about it, and to help keep your up on your education and your awareness of this field, because it's going to change fairly quickly in the next 5 years. So people will talk about, well, I don't want to be in a study. I'm going to be a guinea pig. And we say, well, that's derogatory to guinea pigs because they're furry and cuddly and they don't actually get a choice in the matter. But of course, people decide, they volunteer if they want to be in the study. And so in our hands, we're a member of an organization in the States that helps people become more aware of studies, find studies, match them with studies, and it's called the Medical Heroes Program. So everyone at our site who participates in a study is in fact a medical hero. So thank you very much for listening to me, and I'm going to answer questions afterwards. Pass this on to Justine now.
Thank you very much. So I'll be talking about the next steps if you're interested in learning more for your clients and providing information. So we try to make it as easy as possible for you. And we want to provide your team with a release of contact information form. So if they're prescribing donepezil, rivastigmine, galantamine, or memantine to a client, or a loved one is picking it up, we have a one-page form that provides general information about our research program. And if they're interested in learning more, they fill out their basic contact information and a brief consent form, and that just gets faxed directly to us, and then we can follow up with the patient or the loved one. Next slide. Thank you. To go a step further, we can also provide you with brochures about our research program. We can provide posters that can be hung up in the pharmacies, both as reminders to the pharmacy team, but also client-facing posters. Next slide. Thank you. So I'll send a follow-up email to this webinar. And if you have additional questions, or if you're interested in exploring this program for your clients, you want to request posters or brochures, you can reach me at the number on the screen, or you can respond to the follow-up email, but I'll be sure to include that